Welcome to the LACNETS podcast. I'm your host, Lisa Yen. I'm the LACNETS Director of Programs and Outreach, as well as a caregiver and advocate for my husband who is living with NET. In each podcast episode, we talk to a NET expert who answers your top 10 questions. This podcast is for educational purposes only and does not constitute medical advice. Please discuss your questions and concerns with your physician.
Welcome to the LACNETS podcast. I'm really excited today to introduce Dr. Jennifer Eads. Dr. Eads is an associate professor of medicine at the University of Pennsylvania Abramson Cancer Center, where she is a gastrointestinal medical oncologist focusing on the treatment of and research in patients with neuroendocrine tumors and gastroesophageal cancers. She is the physician lead for GI clinical research, overseeing the Penn GI clinical research portfolio. She is the Penn Institutional Principal Investigator for the Eastern Cooperative Oncology Group, or ECOG-ACRIN, and she serves as the Director of the National Clinical Trials Network, NCTN, for the Abramson Cancer Center. She has served as the Principal Investigator for multiple clinical trials, Phase 1, 2, and 3 clinical trials, including as the National Study Chair for multiple cooperative group trials. She has served on the National Clinical Cancer Network, NCCN, Neuroendocrine Tumor Guidelines Committee, and is a former member of the North American Neuroendocrine Tumor Society, NENs Board of Directors, and she is currently on the Board of Scientific Advisors for the Neuroendocrine Tumor Research Foundation, or NETRF. In 2022, she was named as the ECOG-ACRIN Young Investigator of the Year. Congratulations on that. And clearly, Dr. Eads is passionate about caring for neuroendocrine tumor patients and is very involved in clinical care and research for neuroendocrine cancer. So we're very appreciative for that. A fun fact about Dr. Eads is that she danced competitively for many years, including ballet, point, tap, and jazz. And tap was her favorite, which is really fun. So Dr. Eads, welcome to the show. And we'd love to hear how you got involved in the NET world.
Thank you so much for having me. I really appreciate the invitation. So probably like a lot of us in the neuroendocrine world, I kind of fell into this field a bit by accident. I didn't go to medical school thinking that I was going to be a neuroendocrine expert. I don't think I even knew what a neuroendocrine tumor was. So it was definitely something that happened on accident. When I was a fellow at the University Hospital's Case Medical Center, in Cleveland, Ohio, I worked with a mentor, Neil Mirapol. He was a GI medical oncologist and had been invited to write a review article for a journal. And he said, we can really pick whatever topic we want, what would be of interest to you. And it just so happened that both the everolimus and sunitinib papers for pancreatic neuroendocrine tumors had just been published in the same issue of the New England Journal. So it seemed like a very hot topic. And so we decided to write a review article on neuroendocrine tumors. And after reading about 150 papers to write this review and putting that all together, he said, well, now you know more about neuroendocrine tumors than anybody else at our institution. So this, may be your thing. And then I started also as a fellow to attend the ECOG meetings. And there was a neuroendocrine working group, and I had some very good mentorship from both George Fisher and Pam Coons there. And they really got me involved with writing a trial for high-grade neuroendocrine carcinoma. And so that sort of led to being introduced into the world of NANETS. And I recognized that this was just a small and very collegial community and one where we really have to work together to get things done. And there's not a lot of us. So it just took off from there. And over the course of my now more than a decade-long career as an attending, have really refined, certainly my clinical contingent down to seeing almost exclusively neuroendocrine tumor patients in clinic. And now I'm at Penn, where we have one of the largest neuroendocrine tumor programs in the country. You never know where life is going to take you.
Yeah, what an amazing journey. And lots of big names, lots of amazing work. And thank you for all you've done and continue to do in this field. It really means a lot to all of us. So in the past few episodes, we've been focusing on various types of treatments that are common for neuroendocrine cancer. So somatostatin analogs, targeted therapies, PRRT, chemotherapy. And this episode, we want to focus on immunotherapy. A lot of us don't know a lot about immunotherapy. So if you don't mind, we'll just ask some questions and have a good conversation about it.
Sure.
So the first question that comes to mind is, what is immunotherapy? A lot of us have heard the word. We might have read different news articles that seem really exciting. What is it and how does it work?
Yeah, so I mean, definitely it's all over TV and the commercials, and it sounds wonderful. So the interest in immunotherapy over the last several years has been pretty significant. And of course, everybody wants to try it in every disease entity. So immunotherapy, there are different varieties of it, but it's essentially a way that we utilize a patient's own immune system to attack the cancer cells. Whereas with other types of treatments, like the ones that you've just mentioned, where it may be that we're giving an agent that is known to be toxic to a cell or may target a molecule on the cell, this is really intended to alter the patient's own immune system in some way so as to allow for your immune system to really recognize the cancer as foreign and attack it. So that's the big picture explanation of what immunotherapy is.
That sounds really interesting. I mean, to kind of mobilize your own body's system to attack the cancer. How does it differ from other types of treatments that are out there?
So because it is utilizing your own immune system, I think that is a big difference. If we compare this to something like chemotherapy, where we're essentially giving you just a toxic agent that has been shown to just kill cells by mechanisms that are not necessarily specific, or utilizing anything that has to do with the patient's body, that's very different. Also, we have things like targeted therapy, where the therapy is essentially identifying something that is maybe present on the surface of a cancer cell, and that is what is allowing it to die. But it doesn't necessarily ask the host's body to put in any effort of its own, if that makes sense.
Yeah, this is unique. So what are the kind of immunotherapy drugs that are used for neuroendocrine cancers?
So unfortunately, immunotherapy so far has not been super effective in the neuroendocrine tumor population. Part of the reason for that is that these tumors, as compared to maybe some other types of cancer, so if you look sort of across the spectrum of all types of cancers, there are some that are what we call very immunogenic, meaning that they are very receptive to immunotherapy and are thought to be driven by some kind of immune mechanism. So melanoma is a great example of that. And that's really probably where immunotherapy started to really take off. And we started to see very favorable outcomes utilizing this approach. But if you kind of march through all of the different types of cancers, whether it's colon cancer, breast cancer, lung cancer, et cetera, all the way through neuroendocrine tumors, you'll see that some of them are quite responsive to immunotherapy, and some of them are just not very responsive to immunotherapy. And unfortunately, neuroendocrine tumors are on the end of that spectrum where they're not very responsive to immunotherapy. And we think that a large reason for that is because they just don't divide very quickly. They're very slow growing tumors. They don't have a lot of mutations in them, which is one of the things that is thought to make a tumor more prone to respond to immunotherapy. And so they're just not inherently sensitive to immunotherapies. Now, the patients who have high-grade neuroendocrine carcinomas, those patients have much more rapidly dividing disease, more aggressive disease that behaves similarly to a lot of other types of cancers. And so we have had a bit more success in the high-grade neuroendocrine carcinomas, but not really in the grade 1 and 2 well-differentiated neuroendocrine tumors. There have been some studies over the past few years looking at immune checkpoint inhibitor therapy primarily, so things like nivolumab or pembrolizumab or atezolizumab, and we've primarily investigated it in the high-grade setting because that's where it seemed to make more sense. And when patients with a high-grade neuroendocrine carcinoma receive an immune checkpoint inhibitor as a single agent, that really has not been very effective. But when we give a combination of a couple of different types of immune checkpoint inhibitors, which are essentially drugs that stimulate the immune system of a patient, then those trials have been a little bit more effective. And we do see some responses and improvement in survival outcomes with the combination of a couple of immune checkpoint inhibitors. The other place where it's being assessed is, again, in the high-grade neuroendocrine carcinoma population. A lot of high-grade neuroendocrine treatments have historically been derived from small cell lung cancer treatments. And in small cell lung cancer, a combination of chemotherapy plus immunotherapy has been shown to be beneficial for patients who are newly diagnosed. So by extrapolation, our hope is that that might be the case in patients with high-grade neuroendocrine carcinomas. However, the trial for that to prove it or not is ongoing. So it's not yet a standard practice, but it is something that's being investigated.
Thank you for that explanation. And that's really helpful to hear where in the neuroendocrine neoplasm spectrum it's used and how it's currently being used. Could you discuss maybe a little bit about the other trials, CAR-T, and how that fits and how that compares to the immune checkpoint inhibitors?
Sure. So immune checkpoint inhibitors are antibody treatments. And so basically we give an antibody that targets a molecule that stimulates the immune system. And then that's sort of how the immune system gets revved up to then attack the cancer cells. With CAR-T therapy, that's a different type of immunotherapy. It stands for chimeric antigen receptor, and it's a T-cell therapy. And essentially what it is modifying a patient's immune cells with a particular target that's thought to be of benefit for a particular cancer, and then giving the patient back those cells so that their cells can kind of selectively target the cancer cells. So it's a little more sophisticated and complicated than just giving an antibody treatment. It's something that has so far proven to be most beneficial for patients with some form of hematologic malignancy. But more and more, we are investigating CAR-T therapy in solid tumors. And one example, which I think probably several listeners of the podcast may be familiar with, is one that we have developed at the University of Pennsylvania. So my colleague, Shanshin Hua, he is a basic scientist who has dedicated more than a decade of his work to trying to develop a CAR-T therapy for neuroendocrine patients specifically. And he has looked at several targets over the course of the years, trying to find the target that would most optimally impact a neuroendocrine tumor. I know that in the past, he'd explored the somatostatin receptor. I mean, obviously, that's a favorite target of ours for a lot of different treatments. But ultimately, that didn't seem to pan out to be the best. And ultimately, he has identified something called CDH17 as a target that is present in neuroendocrine tumors and in preclinical models. So like in cells and mice has shown the most benefit. So fortunately, he and I have been working together for the last several years, and he was able to sort of license his work with a company so that we were able to put together a clinical trial in collaboration with this company. You know, it's not a cheap therapy. It's very expensive because it's very individualized. As I mentioned, we have to take patients' cells out of their body, modify them, and then put them back into their body. So it's pretty sophisticated and complicated, but that is moving forward. And as it turns out, this CDH17 molecule is actually something that is also expressed in patients with stomach cancer and colon cancer. So the trial that we have that's starting up is essentially a CAR-T trial for patients with neuroendocrine tumors of the bowel. Unfortunately, pancreatic primary patients are not being included, at least at this time, but it is for the lower grade tumors, so the well-differentiated population of neuroendocrine tumor patients, as well as patients with gastric cancer and colorectal cancer.
Wow, that's so exciting. And thank you and your team for your dedication and hard work. It's really heartening, I think, for the patient community to hear that all this work is being done behind the scenes for literally a decade, and to know that people are working so hard on our behalf.
Yeah, I certainly don't want to take full credit because Dr. Hua has done all of this background work in terms of the science. but we have presented his work and the trial that is going to be happening at patient conferences and also amongst the physician community for neuroendocrine tumor patients. I mean, there's a lot of excitement because we really want immunotherapy of some sort to work. And the hope would be that this can have a sustained effect for people. I mean, of course, we don't know. We haven't tried it yet, but always looking for more options.
Yes, more options. And when you say that it's for the lower grade, well-differentiated, is that G1 and 2? Does it also include grade 3?
It can include well-differentiated grade 3, but yes, they are all well-differentiated tumors and, as I said, intestinal primary site.
Well, that's exciting to have this as an option.
So we've heard CAR-T in the news, as we've talked about, and this is a really exciting trial. We've been watching it for a while. We're really excited to see where it goes. How does this CDH17 trial that you have, how does it compare to other CAR-T trials that are out there? I know Stanford has a collaboration with UCLA and City of Hope on a trial, but there's other CAR-T trials that we hear in the news. Is there a difference with CAR-T trials?
So, of course, any clinical trial is going to have its own nuances in terms of the patient population being investigated or treatment schedule or all of the details that go into designing a clinical trial. For CAR-T therapy, the thing that makes them all different is really the target. So like in a hematologic malignancy, for example, they may be targeting a cell surface marker that is present on the surface of a B cell. In stomach cancer, there are CAR-T trials being investigated looking at Claudin 18.2. So really, they're trying to utilize that target. And so with any of these therapies, you really need to have a target that you're going after. So in the case of our study, CDH17 is the target, but how the T cells are constructed in that between time. So when we take them out of the patient, we do something that modifies the cell. And so that modification was specific to what cancer is being targeted. And then that goes back into the patient, and then that's where we hopefully see activity.
Yeah, okay. So different targets. So each one is unique from each other.
I'm sure for certain targets that are very popular, there are probably several groups that are trying to put together some kind of treatment that may go against the same target. It's a complicated construct that has to be made once the T cells are taken out of the patient and then manufactured into an actual treatment that can be administered back to the patient. In addition to just the target, there's also a lot of other nuanced stuff that goes into what is part of the construct that is allowing those T cells to become different. So from group to group, or from disease to disease, you would see different elements being put into the T cells in order to be administered to the patients.
Okay, that's helpful. And there's been also buzz around a different type of immunotherapy with DLL3. Could you also discuss that and how that might be different from the immune checkpoint inhibitors and CAR-T?
Yeah, so DLL3 is delta-like ligand 3 and is a molecule that is expressed on a large number of high-grade neuroendocrine carcinomas, somewhere around 75 to 80%. Unlike the CAR-T that we were just talking about, where we're looking to target well-differentiated neuroendocrine tumors, DLL3 is not expressed on well-differentiated tumors and is only present on this majority, not all, but majority of high-grade neuroendocrine carcinomas. And there are some agents out there that are bispecific molecules, where it's essentially you have one prong of the medicine that targets DLL3, and then you have another prong of the medicine that is an immune stimulatory element. And so the thought is that by having this agent bind to DLL3 on the presence of high-grade neuroendocrine carcinoma cells, you may be able to stimulate the immune system to preferentially attack those cancer cells. So that is similarly something that has been explored a lot in small cell lung cancer. So we're sort of back to that again, of having relatively favorable results in small cell lung cancer. And the hope, I think, is that we're able to also bring some investigation of DLL3 into the high-grade neuroendocrine carcinoma space.
So a different way to attack the cells. And what about vaccine therapy? That's another one that we hear about and people often ask about.
So vaccine therapy is something that's been around for a long time in terms of strategies that have tried to be investigated. That oftentimes involves injecting some sort of concoction of elements of a cancer. So like something that's been broken up into little bits and pieces and then injected in the hopes that the patient's immune system recognizes it as foreign and can then stimulate an immune response against those elements. So far, that has not been something that has come to fruition, and there's not that many actual vaccine therapies that are available for patients of really any cancer type, but they are still being investigated. And I think, especially with having some of the other immune checkpoint inhibitors coming through the pipeline over the past decade, I think people are becoming a lot more both interested and knowledgeable about the immune system and how to maybe manipulate it so it can affect a patient's cancer. Back when immunotherapy started, I think a lot of people, and by people, I mean physician investigators like myself, we're not really immune system experts. We're cancer experts. And so over the course of the years, we've really had to up our game and learn about the immune system and how it works and all of the sub-elements and what can be targeted and what does what. I think we have a better understanding of all of that. I think people are becoming more comfortable about it, investigate it. And I think in addition to the immune checkpoint inhibitors, the RT therapies, vaccine therapy is something that I imagine will continue to be explored.
Wow. Thank you for that excellent overview. And are there any other type of immunotherapy drugs or categories that are out there that we should know about?
It's surprising to me because just when I think that we kind of have them all, something else comes out. And a lot of these are antibody driven because antibodies are an immune element. Some of these antibodies target just one thing. Some of them target two. And so the constructs are getting a little bit fancier. And I think we've probably covered the majority of them. And I think what the next generation of immunotherapy exploration involves combining them with a different treatment like chemotherapy or refining their targets and how well they bind to the tumor. There's a lot of kinetics and chemistry that goes into how these most optimally constructed. So I think that's probably where things will head next.
So let me see if I understand all this. You've talked about a couple of different categories, the immune checkpoint inhibitors, which are used for neuroendocrine carcinomas, and then several categories of drugs in development. Of course, the CAR-T, and many of them have been used for other cancers, especially blood cancers. But this one that you're developing or have developed at Penn that is going out to several centers is going to be open for the well-differentiated grade 1, 2, and 3 small bowel, which is exciting. And then the other categories, the DL3 vaccine, are being investigated in the high grade, the neuroendocrine carcinoma.
Yeah, I think that's probably where they'll have the most activity because until we can really make the well-differentiated tumors more immunogenic, the utilization of the immune system to attack these cancers is tricky.
So there's a range of different immunotherapies out there. It's not just like one thing, but work being done across the field with different targets.
Yeah.
So I'm wondering, what side effects might someone have when they're taking immunotherapy?
So it is different than any of the other treatments, really in any cancer that we utilize. I mean, I think neuroendocrine tumor patients are in a particularly unique situation in the sense that they get a really wide variety of types of treatments. Lots of cancers, it's chemotherapy, and that's what there is. But for neuroendocrine tumor patients, between PRRT and chemotherapy and targeted agents and liver-directed therapy and somatostatin analogs, it's a very wide variety of agents. And this is yet another one that is really different from all of those. And the side effect profile that comes with it is much different. We talked about the way that it works is essentially revving up your immune system to try to attack the cancer cells. So a lot of immunotherapies, the side effects that come with the treatment is that in addition to your immune system trying to attack the cancer cells, it can attack other parts of your body as well. So you can get an immune-mediated response anywhere. So in your lungs, you can get an immune attack there, and that can be pneumonitis, or in the bowel and development of diarrhea and colitis, or attack of the thyroid, and that's thyroiditis. And really, that can happen in any organ of the body. It can not happen. It can be very mild, or it can be pretty severe. And until we give any individual patient these treatments, we really don't know how their immune system is going to affect their body overall. With CAR T therapy, it's a pretty hefty immunotherapy. And one of the things that we will see with it sometimes is something called cytokine release syndrome, which is essentially where the immune response is pretty massive. And so patients can develop things like fever, their blood pressure can drop, they can have changes in their vital signs that can be, scary. And so sometimes what happens is the immune system just goes too far in terms of its reaction. And so we may have to administer some kind of counter agent to try to pare it back a little bit. And so the side effects are more of an immune mediated nature than things like lowering of the blood counts and nausea and vomiting and the things that you classically see with chemotherapy.
And I think one question that comes to mind is also, how will it make me look? Will I lose my hair? Will I get really thin? How will I look?
So those kinds of things don't really come with this. At least the way our study is designed, it's one treatment. And I think a lot of CAR T studies are that way. Sometimes there might be a second administration, but a lot of times it's one treatment. It's a significant treatment, and it may or may not make someone feel fatigued or experience some of these immune-related complications at some point. But otherwise, it does not cause hair loss. Our hope is that people still maintain their appetite and are able to eat and maintain their weight. And if anything, we hope that people even feel better, and that would hopefully be a reflection of the treatment having an impact and being effective. So it's much different.
And how does it affect one's day-to-day life? Like, can I still go to work? And how am I going to feel on an immunotherapy?
So it depends on what type of immunotherapy. So if one is on the immune checkpoint inhibitors, those agents, well, in neuroendocrine carcinoma, we do oftentimes give them in combination, which is a little harder than getting them as a single agent. But that being said, if they are tolerated well, then we are always hoping with our treatments that we're able to let patients live their lives and continue to do what they're doing and work. I always tell patients that until I give you something once, I'm not really going to know how it affects you. But the hope would be with a lot of immunotherapies, especially that, in addition to it being effective, one of the reasons it's been so popular also is that we're really trying to get away from all the toxicity associated with some of these other treatments like chemotherapy. So with immune checkpoint inhibitors, certainly I have patients who get their treatment and go to work and feel totally fine. With this potential CAR T therapy, it's a little more involved because there's a period where you have to come in and have your cells removed from your body so that they can then be manufactured into the actual treatment. So there's some additional steps that aren't necessarily treatment related, but are still time intensive. And then once you actually get the treatment, then we need to watch patients very closely for the development of any of these immune side effects, and especially because this is brand new and has not been investigated in people before. As part of the trial, at least, we will be watching people very closely for at least a month and longer to make sure that they don't develop any significant toxicities. But provided that they do not, then we hope that ultimately they're able to go on and maintain their daily life.
Oh, that would be wonderful. So when someone is getting immunotherapy, does it cause one to be immunocompromised?
So it doesn't really cause the same lowering of the blood count issues that occur when patients get chemotherapy. And you hear about neutropenia and having neutropenic risk. Now, that being said, we are definitely mucking with your immune system. So things may not be normal. And so I tell people that no, we don't necessarily expect you to have more infection risks or what have you than normal. But at the same time, your immune system is definitely being altered and we're interfering with its normal function. So we need to be cognizant of that. And regardless of any therapy that I give to patients, we can tell people what the whole list of potential side effects is. But I just essentially tell people that I want them to tell me everything that they experience and to not ignore anything, because you just never know. Every patient is different. Every person has their own set of toxicities. Some things we see very commonly, some things we see very rarely. And so nothing is out of range for being a potential toxicity. So that's standard operating procedure.
That's helpful. I mean, just to have that open communication and to let you know what's going on. And when you talk about these side effects or toxicities, how long lasting are they, or are they something that are temporary?
So they differ from the classic therapies in that way as well. Although in neuroendocrine tumor patients, I guess there isn't a classic therapy because there's so many different therapies. But yeah, for lots of treatments, we're used to having you get the treatment and then in a very short period of time thereafter is when you start experiencing side effects. With the immunotherapies, it's a little bit trickier because the side effects could come acutely. They could come right away, or they could come even months after an exposure. So if you look back at a lot of the immunotherapy trials that have been done over the past several years, you'll see that most of them require a follow-up of like 100 days because these agents stick around. I mean, it's not even just that the agent sticks around in your body, it's that the manipulation to your immune system sticks around. And so then it has the potential to cause a toxicity at any point along the way. And so we do follow people for an extended period of time. As we've gotten more comfortable with the immune checkpoint inhibitors, I think that we are more comfortable with what are the toxicities that could come. I mean, certainly CAR T therapy is going to be something very new for us, but I think because the immune system is being manipulated, we do have to watch for a while and things may not be that severe either. I mean, it could be a low severity, it could be more severe. So at least for now, people are going to need to be watched closely, but hopefully we'll get there.
When you talk about watch closely, what does that mean practically for patients? Like, what are you checking? What kind of blood work? What are patients having to go through in terms of the watching?
So at least for the immune checkpoint inhibitors that we use now, we watch people with both a combination of exam findings, clinical history, and labs. So as I mentioned, the immune system can really attack any element of one's body. So if people are telling me that they are having a lot of diarrhea or they're short of breath, I mean, those would probably be the most common things, or they've developed a new rash. Those are things that would lead me to maybe expect that they're having some kind of immune-mediated toxicity. Now, at the same time, we have to remember that people can have diarrhea for any other reason too. And so it can be difficult to parse out. But if we really think that it is immune-related, then if it gets better with a treatment that counteracts these immune treatments, then we know. But from like a lab standpoint, we'll monitor patients' thyroid levels, we'll monitor their adrenal hormone levels. So it's really a combination of clinical history, exam findings, and labs, and sometimes imaging. Those are the things that we're watching.
Yeah, just watching the whole person.
Mm-hmm. Yep.
So we've talked about a lot of different types of immunotherapy, and you've gone over a really clear explanation of what they are and the different ways they're used and side effects. So now kind of taking a step back in big picture, how do you think about this? What kind of neuroendocrine cancer patients, and then how do you decide which kind of immunotherapy you might recommend and for which patient?
So at least within the confines of what we have available to us right now, we limit the use of immune checkpoint inhibitors largely to high-grade neuroendocrine carcinoma patients. At least for now, it's not something that we give to people in the frontline setting along with chemotherapy, although I encourage patients to participate in the trial that is evaluating the combination of chemotherapy plus immunotherapy in the frontline setting. And then after frontline chemotherapy, we really don't have a treatment standard. There are some other chemotherapeutic agents that might be effective, but I think second line beyond is where people are utilizing the combination immune checkpoint inhibitor therapies. It also kind of depends a bit on patient preference. Maybe they've kind of had it with chemotherapy and feel pretty beat up from it and want to try something different. So that might be a reason. And alternatively, sometimes there are patients who are not candidates for immunotherapy. If one has an underlying immune disease, like an autoimmune disorder, you can maybe see why revving up the immune system with the treatment may not be a good idea for that situation. And so that's something that we have to take into consideration. So that's really how we utilize the immune checkpoint inhibitors with this CAR T trial that we have pending. Because it's first in human, it's brand new, we're just learning about it. While we know that we want to have patients who have a well-differentiated neuroendocrine tumor, we also want to make sure that they're in a good spot for being treated with a treatment like this. The same issues apply. We don't want the patients to have an underlying autoimmune disease. And we want to make sure that they're not having any elements of their disease that are concerning, such that we think that they would benefit more from some other kind of treatment right now. I imagine over the course of many of these podcasts, it's been relayed that there's no one standard way to treat any neuroendocrine tumor patient, that it really depends on their clinical situation at any given time, their disease distribution, how they're feeling, their side effects, their comorbidities. And so just like with any of the other treatments that we interject at any given time in a patient's journey, I think the same is true with the immunotherapies, that we have to feel like it's the right time to use it. A lot of these treatments are not necessarily fast acting. And so if somebody is really having a lot of pain or having a large disease burden and really needs something to work quickly, it's probably not the right time. It'll, I think, ultimately be the same as with a lot of the other treatments that we have. We have to gauge, is this the right time to use this particular treatment for this particular person?
So well said. I think one thing that really jumps out to me, other than how it has me individualized, is really then the value of a NET expert to really assess and guide and evaluate, and then be able to recommend when is the right treatment for the right person at the right time.
Yeah. I mean, that's why I think lots of groups such as yours and many others have said, even if patients get treated locally, ultimately, because it's much more convenient, that patients really do benefit from having an evaluation at a neuroendocrine tumor center of excellence with disease experts to make sure you're optimizing your treatment options in the order in which they could best be administered.
And because people like you also know what else is coming down the pipeline or is already on the horizon, and what other options might be a possibility for clinical trials and the nuances of them. So we'll end with this last question. What do you see as the future of immunotherapy in neuroendocrine cancer treatment?
I think we are optimistic that we can make an impact with immunotherapy. It's a little different depending on the type of immunotherapy that we're talking about. I think already people are using dual agent immune checkpoint inhibitor therapy in high-grade neuroendocrine carcinoma. I think there's hope for the DLL3 targeted strategy in high-grade neuroendocrine carcinoma. So getting those trials underway to assess if there's benefit for those. I mean, I think that's going to be the next thing. And then whether or not that should be administered as a single agent, or should that be given in combination as well. And then on the CAR T front, I think we're really early. We have great preclinical data in mice and in cells. And so I think we're very optimistic that we have the right target. Solid tumor CAR T therapies have been a challenge, but some of them have been showing really favorable results. So I think we need to get more experience with the toxicity, how they're administered, who best benefits from them. And hopefully it will turn into something that is effective and beneficial for people.
Hope. We have a lot of hope. Thank you for giving us that hope. It's really exciting. This has been very informative and also really exciting to hear all the progress that has been made and that is about to be made. There's a lot of trials that are open right now or are opening, such as the one you mentioned, and we really look forward to continuing to see the progress, and we're really grateful for you and your team and all the work that's been done and will continue to be done. Thank you for all you do on behalf of the neuroendocrine cancer community.
Of course, it's my pleasure. It's a wonderful patient population. Happy to be a part of it.
Well, we're grateful for you, and thank you for being here today.
Thank you so much.
Thanks for listening to the LACNETS podcast. Go to our website, lacnets.org/podcast for episode transcripts and resources. We want to thank our podcast supporters, Novartis, Ipsen, ITM, Crinetics, Curium, and Boehringer Ingelheim. For more information about neuroendocrine cancer, go to www.lacnets.org. LACNETS depends on donations to bring you programs such as this podcast. Please consider making a donation at lacnets.org/donate.